important contribution in IgA nephropathy and other glomerulonephritis, obviously. And we'll be talking about new and next therapeutic approaches for IgA nephropathy. Thank you, Robert.
Thank you, Renato. So you're all well prepared, and we can go straight to business. Well, let me draw different clinical scenarios. Here's a very beautiful study from Sweden, published recently. IgA patients with a benign clinical presentation, isolated microhematuria, no or low-grade proteinuria, and preserved GFR. So I think we would all agree that this patient just needs surveillance and no treatment. And so far the textbook says this is a benign condition. If you follow, like they did in Sweden, these patients for 20 to 25 years, a third will lose IgA nephropathy spontaneously. 50% will have persistent proteinuria, but a preserved GFR after 25 years. 20% will have progressive CKD, 5% will have advanced CKD. And the bad news in that paper is that it's impossible to identify the patients, the few patients that will progress. Now, the first bad implication for therapy in IgA nephropathy is you have to bind patients to yourself and you have to observe them for really prolonged times, maybe for life. So Jan Novak has already introduced the 4-hit hypothesis on how IgA nephropathy evolves. But this mere observation from Sweden, which I just showed to you, implicates that there must be very potent modifiers that determine whether you spontaneously lose IgA nephropathy or whether you are among the very few who progress to end-stage renal failure. And this could be, of course, genetic background, but it could, of course, be generic progression factors. Hypertension. Half of us will get hypertension, so that's a potent progression factor. Obesity is a progression factor. Smoking is a progression factor. So there are many things that will affect the course of IgA nephropathy, and that, of course, opens a lot of opportunities for prevention of progression. So step number 1, as you heard, is the increased occurrence of IgA with poor galactosylation in the circulation. And I believe we all feel that the most interesting approach here is Bengt Fjellström's paper on targeted release budesonide. So this is good old budesonide. Our friends in gastroenterology have used this for decades. But this is in a special formulation where the central release is in the terminal ileum, figuring that this is the area of the highest density of pious plaques, and this is where you want a local corticosteroid to dampen whatever inflammation you have down there. And much to our surprise, this is a phase 2 trial which had an endpoint in proteinuria. Much to our surprise, this relatively short trial, treatment over just 9 months, led to a stabilization of GFR. So this is not yet available. A phase 3 trial just started, and we'll see what happens in that large phase 3 trial. So elimination of causal infections or antigens, of course, would be the aim. And it will be very interesting to see what comes out of the French gluten-free approach. Maybe that at least works in some patients. And Renato also pointed to the option of maybe modifying infections or the microbiome and thus preventing IgA nephropathy, but this is really far from any clinical reality so far. So right now we're left with a relatively non-specific yet potentially effective approach, which is intestinal steroids, dampening the inflammation and at the same time, of course, avoiding the pronounced systemic effects of high-dose corticosteroid therapy. You heard from Jan Novak that the second hit is the generation of IgG antibodies against this poorly galactosylated IgA. And that, of course, would make a case for immunosuppression. Here we would have a classical autoimmune disease. But IgA nephropathy is funny. It doesn't really fit, in my personal opinion, into a classical autoimmune disease. Well, first of all, we did this trial some years ago, and I don't get tired in mentioning even to you, you're the good ones, you know how to treat these patients. But even you need to sit back and reflect, did I do really everything in terms of supportive care that I can do? Just giving an ACE inhibitor is not enough in IgA nephropathy. And this is probably my most important slide. Send me an email, I'm happy to mail it to you. But you can do more than just giving an ACE inhibitor. ACE inhibitors should be up-titrated. If you still have proteinuria, you can do dietary approaches. You can restrict sodium intake. Here's a really bad sentence. Control all components of the metabolic syndrome. That means lose weight, exercise, walk. Stop smoking. If you smoke, you have a tenfold increased risk in IgA nephropathy to end up on dialysis. This is an incredibly potent progression factor. So you can see from this list that there is a lot you can do in terms of relatively safe, relatively simple therapies. And as Rosanna Coppo stressed, this should be done before you consider anything else, unless you have a patient with rapidly progressive glomerular disease in the course of IgA nephropathy. And this is effective. This is from our trial at the start of the 6-month run-in period, so we didn't do anything to them except optimize supportive care. After this 6-month run-in period, look how hypertension control had changed. Instead of 30% with overt hypertension, we had 9% with overt hypertension. And the patients with a blood pressure below 140/90 increased from 70 to 91%. And there's good data from Korea that 4 millimeters of mercury decide whether you have a stable course or whether you slowly lose renal function. 4 millimeters of mercury decide about the cause of IgA nephropathy. So in our trial, indeed, immunosuppression did work. It induced more clinical remission. And we're just looking at the patients after an average of 7 to 8 years to see whether this translated into a better outcome in the very long term. But at the same time, we failed to observe any benefit on GFR. And the patients losing more than 15 mL of GFR in the 3-year study period were absolutely not affected by immunosuppression. And the notable thing in our trial was that instead of earlier trials, and this is just one of them, many trials, if you look at them in the placebo or the ACE inhibitor only arm, have a GFR loss around 5 to 6 mL per minute per year. So way above the physiological GFR loss. Ours in the supportive care had minus 1.6, close to the physiologic GFR loss. Again, stressing that you and I can do a lot by simple measures in retarding progression. And of course, this is what you should do first. The big trial that was supposed to clarify the role of corticosteroids in IgA nephropathy is the testing trial. In this testing trial, we had aimed for a very large trial, 750 patients with IgA nephropathy. They had more than 3 months of RAS blockade, and then were given oral methylprednisolone at 0.6 to 0.8 milligrams per kilo per day, so roughly about 1 milligram per kilo in prednisolone equivalent, and then tapered. The trial was stopped. It was stopped by the Data Safety Board after it had recruited about 250 patients, and it was stopped because in this very first phase, the methylprednisolone group experienced an excess of adverse events some of which were lethal infections. Unfortunately, the GFR also improved in the corticosteroid patients, so we are left with the dilemma that we killed patients but stabilized their GFR. A most interesting trial is with rituximab. Rituximab over the course of 1 year did not affect proteinuria in IgA nephropathy. It had no GFR effect either, but there was hardly any GFR loss. Now this is very notable. If this is a true autoimmune disease with IgG antibodies playing a dominant role, why doesn't rituximab work? It works nicely in membranous, it works to some degree in other autoimmune diseases, but it doesn't really work in IgA nephropathy. And the puzzling observation was that the levels of galactose-deficient IgA were not affected by rituximab, suggesting that these are plasma cells, particular plasma cells, maybe from the intestinal mucosa, that are CD20 negative. Mycophenolate mofetil was briefly touched upon, is a funny thing as well. For all we know, it has no effect in Denmark, because here we have mostly Caucasian patients. It does work in China. Small studies, but it's relatively consistent that proteinuria is reduced and GFR is better. And I guess Sidney Tang's study from Hong Kong is the best study, best documented. Small, but note an important difference here. 30% were men in the Chinese study. This is very different to Denmark, or the rest of Europe, where IgA is a male disease. And you can also argue that 2 grams of MMF for an average Chinese person is much more than for the average Danish person. We don't know that, whether this is a dose effect, but this has an important implication. The implication is that IgA nephropathy in China may not be the same as IgA nephropathy in Copenhagen. We just call it IgA nephropathy. Rosanna Coppo already showed you this slide from Nanjing, where they compared MMF and moderate dose steroids with high dose steroids. It didn't differ. Side effects were less, but clearly it did work. But this study has a downside. If you look at the fine print, these are the amazingly well-matched baseline criteria. Everything was in perfect alignment. And 24% of the patients received an ACE inhibitor. Look at this, 24% in a study where the patients had a baseline proteinuria of almost 2.5 grams. That shouldn't be. And just as nice as that trial is, it's frustrating to see that supportive care wasn't used to the extent it could be used. BAF is another new target in IgA nephropathy. BAF regulates B cells and a lot of the immunoglobulin production. There's a lot of drugs that target this whole family, from atacicept to belimumab, which you know well from lupus, to blisibimod, which has been tried in IgA nephropathy. And the rationale is that BAF transgenic mice develop something that looks like IgA nephropathy, with all the caveats that Renato Montero mentioned for mouse models. And serum BAF is elevated in patients with IgA nephropathy, but then you have to see that BAF has a molecular weight of 32 kilodalton, and lots of low molecular weight proteins accumulate in the serum if you have chronic kidney disease. This is the data as was presented at the ASN in 2016. To my knowledge, the data is not yet published. But what was found, and the key slide is here, these are the placebo patients, these are the BAF patients. And the interpretation was that blisibimod worked. Well, you can argue about that. Blisibimod did not reduce proteinuria. There's something odd with the placebo group, which increased proteinuria, which is fairly unusual in IgA nephropathy trial. in most situations and most trials that have been published, the placebo group had a relatively stable proteinuria, and if at all, treatment reduced proteinuria. This is somehow the opposite. So it's uncertain whether blisibimod had a major effect here, and we will have to wait for the final publication. So immunosuppression, steroids clearly work. High-dose steroids, at least in China, have a safety signal. Rituximab, at least from what we know, is off the list. It doesn't affect the levels of IgA, galactose-deficient IgA. MMF is funny, it seems to work in China, but not so much in Caucasian populations. Blisibimod is uncertain whether it really worked. It didn't do anything to proteinuria. And there's an ongoing trial with a tyrosine kinase inhibitor against SIC, spleen tyrosine kinase. It hasn't been published yet, but we are about to hear about that trial. The next step, as you heard from Renato, is mesangial deposition and formation of IgG-IgA immune complexes. Yes, you can remove glomerular IgA, and Renato mentioned his IgA protease, but it's difficult to conceive this over 20 to 25 years giving a protease. So Renato, I absolutely agree with Renato that the likely indication may be the rare patient with vasculitic IgA and a really clinically, and I'm stressing clinically, rapidly progressive course. And then you have engagements of IgA receptors and complement activation, and we have a large number. Pharmaceutical industry, thank God, finally gets interested in IgA nephropathy. We have at least 4 trials that are about to start with complement inhibitors in IgA nephropathy, ranging from MASP2 antibodies, which is the key enzyme of the lectin pathway. There are 2 companies looking at factor D, the central regulator of the alternative pathway, which of course targets much more than just one molecule. There's companies looking at C5. So far we have a few case reports on eculizumab. We have one after transplantation where eculizumab was not effective, so it's uncertain. Or even targeting C3. So I'm certain that in the next years we will hear and learn much more about the role of complement in IgA nephropathy. And finally, as has been mentioned before, many of my patients present with active glomerular disease, but they already have a GFR of 40. So you also need to target the events downstream, and in particular antifibrotic agents. And it's, in a way, it's a shame that one of the parallel sessions today is a session on renal interstitial fibrosis. This is a very relevant patient approach, maybe combined with dampening the initial glomerular inflammation, but you should also target the interstitium. And I think in the future we will see multi-therapy for these patients, and in all likelihood individualized multi-therapy, depending on what antibodies you have, what histology you have, what genetic background you have. So IgA will be a very interesting theme for the future. Thank you for listening to me.
Thank you, Ruben, for this brilliant presentation. So some time for some questions.
Very short question. Do you consider combination of ACE and ARBs in the IgA in contrast to all the cohorts of cardiology?
Well, we looked at this in the STOP IgA trial. It's not published yet, but in those days, quite a number of patients were receiving dual RAS blockade. And while it was safe, it was no better than single agents. So essentially, we've stopped doing that, and I would rather suggest you up-titrate your ACE inhibitor or ARB.
Okay, if no more questions, thank you for your presentation. Thank you for the audience.